This is Alessio LaManna, and together with Roberto Garbo and Gabriele Gasparini, we welcome you to the second webinar organized with the support of IMDS on everyday efficiency and complete revascularization. Today's webinar is focused on CTOs, and particularly on the Antegrade approach. We know that CTOs are still the main obstacle for interventional cardiology in order to get a complete revascularization. So, since CTOs are relatively frequent in patients undergoing coronary angiography, we know that there are around 20% of patients with CTOs undergoing coronary angiography. It's very important that, of course, operators, modern operators, advanced operators, are trained in order to perform this complex PCI. So first step today is Antegrade approach. In the next webinar, we will discuss the retrograde approach. For those who are new to this webinar, there is a chat on the IMDS website where you can discuss with us about the topics we are presenting. Since during the webinar, we will discuss cases that we record in our everyday practice, you can, of course, interact with us to make any kind of question or comment, because, of course, it's very important, the interaction, in order to have a full understanding of this very important topic. So this is the most recent algorithm that has been presented last year, or your intervention. This is so-called European algorithm to CTO PCI. And this is the sort of summary of previous algorithms that have been published by the North American colleagues, the so-called hybrid algorithm, and the ASEAN Pacific algorithm. For those, of course, who have for the first time look at this algorithm, it seems very complex because there are a lot of arrows. It's a sort of labyrinth. And this is just to show how complex can be the approach to CTOs. But the approach to CTOs is less complex as it appears from this algorithm. We have mainly two kinds of approach. We have the Antegrade approach and the retrograde approach. And of course, there are anatomical characteristics of the CTO lesions and the coronary tree that should be considered in order to choose the most appropriate one. So the Antegrade approach is the topic of today. It's very important because it's the first step for any interventional cardiologist who want to start the CTO PCI to have experience with this approach. And there are several ways to face these lesions using the Antegrade techniques. So the first one is the Antegrade wire escalation technique. This is based on the use of microcatheter and wires in order to go from the proximal true lumen to the distal true lumen, keeping the system in the intimal space. So, of course, this is mainly used in case of less complex lesions, so short occlusions or longer occlusions in straight segments, or in those cases where navigable microchannels are suspected, and in some cases of instant CTOs. So we should start with soft polymeric tapered wires like Fielder XT or Fighter wires, and then in case we are not able with scanner wires to get into the distal true lumen, we should escalate to more stiffer wires like the Gaia Second or Confianza Pro 12 in case the course of the vessel is known. Otherwise, we should use other kind of wires like the Palo 200. This is an example of Antegrade wire escalation technique. This is a mid-RCA CTO. This is a diffusely diseased vessel with a double 90 degrees angulation at the level of the CTO. You can see that the lesion seems to be very long, since from the contralateral injection, we can see only the distal part of the vessel with the bifurcation, with the cracks. So I approached this case with a microcatheter. In this case, I used an Answer Pro X, the new version of this microcatheter, single lumen microcatheter, and a Fielder XTR. So as you can see from this clip, the Fielder XTR progressed into the CTO lesion, probably because of the presence of a microchannel, but then it stopped. So I escalated to a Gaia first, and I was able to get into the distal through lumen. This clip you saw the enhancer Pro X can advance into the doubly angulated vessel very smoothly. And this is a very important step of the procedure, because after wiring the distal through lumen, we have to switch to a workhorse wire. And this was done very, very easily. These are the characteristics of the Enhancer Pro X. This is the new version of the previous Enhancer Pro X that has been improved in terms of pushability. So the penetration force has been increased. And still there is the torque device. This is a feature that is unique of this microcatheter. Using this torque device, you can lock the wire within the lumen of the microcatheter to make a single system, so the so-called hybrid guide wire shaft lock. In this way, you can handle the guide wire, rotating the microcatheter as a unique system, and this may increase the penetration power of the wire. So even a soft wire can get, with this system, stiffer. And this is the final result after stenting. So Antegrade wire escalation is very important because, again, can solve many cases. This is the first step to start with. So now I give my word to Roberto. Roberto, are you there?
Yeah. Thank you. Thank you, Alessio. We can go with the. I try to go on with my presentation. Okay, wait. This is your case, and this is what you have said in the beginning of the webinar is right. Then says that in a sort of learning curve of CTO operator, the Antegrade approach is the key of our procedure, and we can have really complex Antegrade CTO PCI. Antegrade doesn't mean easy, and because people sometimes think that complex CTO are only retrograde CTO. Sometimes to have a retrograde possibility is makes much easier the procedure. So we focus on Antegrade CTO PCI, and the first after Antegrade wire escalation, another very important step that is I think that sometimes underused is the parallel wire technique. Parallel wire technique is part of our way to treat this patient, and the most modern in the modern era, and parallel wire technique had to be done with the dual lumen microcatheter. In my mind, now we have a very new microcatheter that we will see during this session. The name is Recross, and this is a particular dual lumen. But I want to show you also some cases with the old dual lumen situation. We have this case that is an interesting LAD CTO ostial, really ostial, and it was done some years ago because in that period it was not available, the Recross. I went with an answer. I tried to not to use dual lumen in order to treat in a normal fashion, like with a single microcatheter and the filter XTR. You can see here you have the prolapse of this wire. So because of the angle, because of the ostial lesion, I was not able to direct my CTO wire in the proximal cap. After that, I switch with the dual lumen technique that has two advantages. The first one, we have a wire in the circ that is really important in this situation, because if you have a dissection of left main, you have a safety wire in the circ. And the second point, that we can use a regular dual lumen like an Enhancer X. In my mind, this is the best dual lumen we can have on the market now, because is you can see here you have two tungsten but radiopaque part, and in the middle you have a part in which is the exit of our CTO wire. Then the second point and is the structure of this dual lumen is oval, and so also in a normal PCI with 6 French we can use trapping balloon, and so this is very important. In this particular case, this is the same situation. Filter XTR, but with dual lumen, and you can see the difference on respect of the other case. With we have much more support and much more pushability of the wire. So I was able to enter in the proximal cap of the lesion, and then I check with IVUS. This is the IVUS of the situation. It's clear that we have a very good puncture with filter XTR in the mid of our, you can see here, this is the wire, and this is all the LAD ostial proximal cap. So we have a good puncture, but despite this good puncture, I went subintimal with my Gaia second. This is the retrograde check that show that I'm subintimal, and I am in the upper part of the vessel. So in this situation, we can use parallel wire technique, because we know that we need to be down with our second wire, and we have two important features. The first one, with IVUS, we know that we puncture in a good way. So the initial part of the CTO was done correctly, and then we went subintimal. Why? Why? Because our wire is not enough stiff to penetrate the body of the occlusion. So in this situation, when we take a second wire in the parallel wire technique, the second wire has to be stiffer than the first one. This is a very important point. So I take a Gaia third, I put a dual lumen again. So this is an answer RX in the over the Gaia second. So I switch from the circ to the Gaia second with the dual lumen, and then this is a fluoroscopy registration storage with Gaia third, that we know that we need to direct down to the first wire, and this is a real-time fluoroscopy. You can see the Gaia third that easily went quite far from the first wire. So this is the classical situation of the first wire subintimal and the second wire intimal, and you can see how easily the second wire went in the lumen. And then the check, you can see the check that confirm that we are good. This is another angio to make a sure confirmation, and then at this time was easy to close the procedure with the stenting and the very good result of also the level of left main and the LAD. So we have we know that dual loop. We know that in the 30% of case we can have bifurcation and CTO. So I want that Gabriele explain us how we can manage this kind of CTO in bifurcation. So please, Gabriele, if you can speak.
Absolutely. So first of all, I would like to just a few considerations regarding your case, because as you underline, Antegrade CTO doesn't mean that is an easy CTO, but the correct utilization and the correct knowledge of the dedicated device could overcome and simplify a complex PCI or complex CTO, like in this case, because using the dual lumen microcatheter, you were able to more support in order to puncture this difficult entry point, also due to this unfavorable takeoff of the ostium of the LAD. And then once you puncture and you confirm your correct position with the IVUS, the wire, despite the correct puncture, went subintimal. And in this case, the use of the dual lumen, the same dual lumen microcatheter that you used before to puncture, was useful to gain the distal true lumen, to gain the correct pathway in the artery. So it's a very good and teaching example how a dedicated device and a correct utilization of the device could simplify and overcome some difficulties that you can find during the procedure.
Yeah, also because I think that is the concept that we try to stress about the method, about to know what you are doing. And if you change with a second wire, a second microcatheter from the beginning, in this case, you are not sure to enter the same good position of the wire. So this is the meaning of using dual lumen. So we know by IVUS that the first part was good, and we take dual lumen in the first wire, and then we change the second part of the position of the CTO. So I completely agree with you. Thank you.
Thank you. So now go on with the next case. Another application is it's quite similar, the application. When you have a CTO close to a bifurcation, that is quite frequent and could represent difficulties because the lack of support, or because sometimes when you have a CTO close to a bifurcation, the blunt is damp. So the use of dual lumen microcatheter could help the operator to perform a correct position, especially due to the support. Because if you advance, you have to remember that when we use a dual lumen microcatheter, the exit port is on the tip. It's the rapid exchange exit port. So you have to advance the dual lumen microcatheter over the wire that it's on the wire that is placed in the side branch through the rapid exchange lumen. Then you have the lateral exit port that is the exit port of the over the wire. So once you advance the dedicated CTO guide wires, you are using the lateral exit port, like in this case on the right side. So this is a standard workhorse guide wire that was advanced in this left circumflex, and then we advanced it to the over the wire lumen ultimate broad 3 guide wire. That was it was quite easy to perform the puncture of the entry point, the proximal entry point. In this case, the presence of this island very close to the occlusion helped me in order to understand that the progression of the wire was good, without the need to perform an IVUS in order to check the correct progression of the wire into the intimal tracking. And then once I had the confirm that was lumen, the true lumen, I had to exchange obviously the dual microcatheter, because in this case I can't advance. You will go at the end of the presentation to discuss about the versatility of the new dedicated dual microcatheter, such as Recross, that could be advanced. But in this case, it's not possible to advance the microcatheter even if you remove the wire in the side branch. So you have to remove the microcatheter, the dual lumen microcatheter. For this reason, it's very important to know the compatibility with the guiding catheter, because it could be different if you are using a different dual lumen microcatheter and the different catheter. So in this case, I removed the dual lumen microcatheter with the trapping balloon. I was using a 7 French guide catheter, and then I advanced a single lumen microcatheter that was an Answer Pro X that was very easily advanced into the proximal cap. You can see the progression of the Miracle Bros 3 wire, and then the easy progression of the single lumen microcatheter until the distal true lumen. Once I arrived into the distal true lumen, I remove the wire and I exchange the wire, and finally, this is the final result. So this is an interesting example of how this kind of device could help you even in case of unfavorable anatomy, like in case of CTO in site of bifurcation. So I think that now this is another case of Roberto. So I give you the line, Robbie, for the next case.
Yeah, this is another case of bifurcation in the context of CTO. We have this circ. A circ is always a complex anatomy, because you need to, very important when you need to open the circ, you need to see multiple projection, because sometimes you feel with the angio, you think to be in intraplaque, to be in the true position. Then when you go in the orthogonal view, you are completely outside and you can have perforation. So you need to be very careful when you need to check this kind of lesion. And with this case, I start with the dual lumen, the bifurcation, and I have a failure with Gaia second, Gaia third, and then I need to have a parallel wire strategy with Ornet 14. You can see here, and I gain obtuse marginal branch with the Ornet, but it was not the big one. It was this one, a small one, but it was really interesting, really important, this situation, when you gain a branch, not remove your wire, but use the first wire to advance your dual lumen microcatheter and try to gain the bigger branch you need to open. So in this situation, I was happy to gain this branch, and I would like to advance the enhancer RX in order to obviously changing the position of the dual lumen from the side port to the RX in the Ornet, in order to use the side port with for the second CTO wire, because also at that time Recross was not available. But we have some problem, because I was not able to advance the dual lumen. I was not able to advance the Tazuna. So we are in a situation that we will show later, but in this case, we can see now of uncrossable lesion. So you cross the lesion with the wire, but you're not able to cross with your device. So this situation, we have, in my mind, two possibilities. The first one is to inflate the balloon and try to broken to make a crack in the plaque like a granuloplasty, but the most you extend your dissection, you have this risk. And another option is to use this new very interesting device, the blimp, that is a very particular balloon that we will see later in detail. Is a very small one with a very small rapid exchange part of only 5 millimeter and 0.5 millimeter balloon. And you can see how easily the blimp cross this hard plaque of the CTO, and opening and dilating with the blimp. The next situation was easy to obtain crossing with dual lumen, and then with Gaia second, this is a real-time fluoroscopy registering of this movement of the Gaia in the big posterolateral branch. I was able, you can see here, to gain correctly to cross correctly the CTO in the mid of circumflex, and then to have very good final result with every branch open. You can see the big branch of the posterolateral circ, and then the small branch a little upside. So this is another situation which was the dual lumen was really important. I think that's in my mind we have two kind of device that are really a revolution in our procedure: dual lumen microcatheter, and especially now that we have Recross, I use, when I need to face CTO and bifurcation, I use always the Recross, and then guide extension that are really useful in many situations. And we can give the floor to Gabriele to explain this fantastic device for CTO.
Okay, it's very important for us. Can you hear me? Okay, so it's very important for us to understand what is the real difference between the standard dual lumen microcatheter that all of you knows and the new Recross device. The main difference is the presence of dual lumen that are not, both of them are over the wire lumen. So this is the main difference, because in the standard dual lumen microcatheter, we have two lumen. One is a rapid exchange lumen, and the second one is the over the wire lumen. But in this case, we are talking about a device with two over the wire lumen. This is the main important thing that we have to keep in mind, because in CTO PCI, it's very important to have the different over the wire lumen, because these features allows us to change the wire, both the wire, if we are deciding to use the white lumen or the blue lumen. So the presence of two different over the wire lumen, it's very useful in CTO PCI when you have to change the wire quickly, or we have to change the strategy, or we have to perform an antegrade wire escalation to choose a stiffer wire in case of the parallel wire technique. So, and then the second main difference is the presence of two different exit ports. So for this reason, if we were using a standard dual lumen microcatheter, the only way, the only possibility that we have just to make a small rotation of the system. This is not really a rotatable microcatheter, so it's not so easy to rotate and to redirect the lateral exit port. And if you want to do it, you can do it just between 180 degrees. But the presence of two separate dual lumen, I'm sorry for the noise. I think that we have some noise. I try to remove the noise. Okay, sorry. In this case, we have two different exit ports that are located at the distance of 180 degrees. So for this reason, if you try to rotate the microcatheter, and you have the availability of two different lateral exit ports, you can use this device in a 30-60 degrees. So like in this case, this is very clear picture of this concept. So this is the second main technical features of this device that could be very useful in case of CTO PCI. And then the third important technical features is the crossing profile. The crossing profile is the same of the standard enhancer RX dual lumen microcatheter. So in this case, you can use it and you can advance it without any problem due to the low crossing profile. And then the I think that we have some interesting cases that were performed by Roberto that we can see in order to understand the versatility of this new device.
So if you want to, with Alessio, you can.
Yeah, I would like to ask just regarding the features of the Recross, because it's very important, even the guide catheter compatibility. So is it, since this microcatheter is the same profile of the Enhancer X, this is very important because it can be used with I mean, you have more the possibility of using it with the 7 French guiding catheter, with the IVUS. What do you think about that? as compared to other microcatheters, since it's can be trappable with a 6 French as well, no?
Yeah, I think that this is really a revolution catheter, microcatheter for CTO, because we have so many solutions in the very small profile of microcatheter. Because if you think that you can do all this strategy, you can use as a single microcatheter, because you have a stylet in the second port, and then you can go through the tip. You can use a CTO wire like a normal microcatheter. You can use with the 2 CTO wire contemporary. You can do parallel wire with the 2 CTO wire, because you have a white port and the blue port. You remove the stylet and you can use the second CTO wire in the blue port. You can use for ADR. We will see a case later. But all this situation, as you explain brilliantly, is very you can do with a device with a very small profile. You can do normally we don't use 6 French for CTO, but if you need to do CTO in a particular case with 6 French, you can use this microcatheter and you can have a trapping lumen together. So this is a really a revolution, because it means that the profile of this device is really good. And I can show you this case and we can comment together, Alessio or Gabriele.
Okay.
And this was a right CTO, and like in this case, I want to start with Recross from the beginning, because I wanted to evaluate the feasibility of use only one device, only one microcatheter for all this kind of procedure. And I start with the Recross, you can see here, and with filler XTA. So we have the Recross with the stylet in the blue port and the filler XTA in the through the tip. Seems to be a normal microcatheter, and you can see the filler XTA. This is a fluoroscopy registration, like live in a box, and went in a side branch. So you can see that I need to push a lot, and I went not in the right. I do the injection, and now perfect. Okay. So this is a classical situation in which you face bifurcation at the distal cap, and you reach the side branch with the further. So in this situation, Alessio, which is for you the next step that you want to, if you want to explain to a young operator at this moment, what you will do for a next step of this procedure?
Okay, can you show again the point, because I had trouble with the connection. So just to see the point where we are with the presentation.
Reach the side branch.
Okay. So
you see here now.
Yeah. So as you said before, once we get into a side branch, it's very important not to lose this position, because this is a point where we can start to work on the CTO body. So at this point, it's very important to have a dual lumen microcatheter to advance up to the site of the bifurcation. Sometimes to do that, to advance the microcatheter, you need to pre-dilate, but with this very low profile double lumen microcatheter like the Recross or the Enhancer X, you can advance even without pre-dilatation, because the stylet can help you to increase the penetration force. So up to there, at this point, you can try to advance. You can advance on the over the wire lumen a second wire, stiffer wire with a double band at the tip, in order to try to advance into the body of the CTO lesion and to get into this distal lumen. Sometimes another thing that you can do is to do an IVUS guided puncture at the level of the bifurcation, so you can pre-dilate, and using a dual lumen microcatheter and the IVUS, you can try to puncture the lesion more properly in order to advance into the intimal space. So what I would do here is just to advance the recross, that is this new microcatheter up to the lesion, to the bifurcation, and then try with a second wire, a stiffer wire. That's what I would do.
Great, great. So this is what I did. I want to test this microcatheter in this situation, and this is the confirmation that our feeder XTA is in a side branch, and this is the recross, and this is the crossing. You can, yeah.
I would like just to make a comment on this slide, because I think that it's very important to explain using the video and the picture. So what you did was to advance through the white lumen, okay, filter XT. So in this case, Roberto advanced the Recross device in a sort of single lumen microcatheter, okay, because this is a lumen that is the exit port of the tip is of the white hub is on the tip, and the second one from the same white hub is lateral. So if you advance through the tip, you can use it, you can advance it in a sort of a single lumen microcatheter. He advanced it with the filter XT. Once the microcatheter was advanced at the level of the bifurcation, because he gained a side branch, not really the main vessel, he removed the stylet. He removed the stylet from the blue hub, and he advanced a second wire through the over-the-wire lumen that went out to this different lateral exit port, different from the white hub. So in this case, he used as a single lumen to advance through the CTO body to gain the side branch distal through lumen, and then at the same time he used it as a dual lumen microcatheter from the blue hub, from the blue lumen, that has only just one lateral exit port. So in this case, it's very versatile. Isn't it? It was what you've done.
Yeah, and you had a fantastic explanation, and you can see here we need to do an anchoring balloon. So you explain always in your course and to young operator that anchoring balloon, even if you have amplats with a very good passive support with the amplats guiding catheter, you need often to use anchoring, because we cannot lose the filter XTA from the side branch. And what's really easy, you can put a 2 millimeter balloon in the side branch, in the upper side branch, with the recross. It was no friction, and then you can push the recross, and as you can see, and then you can remove the stylet, and you can put a second CTO wire. In this case was a judo wire, a judo 3 that really easily went into the CTO at the level of bifurcation. You can see here, and the wire reached the distality. Now we have a confirmation. You can see. Perfect. So we have recross, anchoring, judo, and then what's happened? So I stop here, and then Gabriele, what's after that? Which is your next step in this situation?
Okay, in this situation, you have two different wires into the two different branches, but both of wire are CTO dedicated. This is a filter XT wire, if I remember well, and this is the judo wire. So in this case, the safer step is to change the wire. But to change the wire, you have to remove this. Okay, you can change just the first one, the filter XT, because you are using the over the wire lumen through the white hub that is on the tip. So you can remove, leaving this recross in the position. You can exchange the filter XT with a workhorse. But to exchange the judo 3 wire, you have to remove using the trapping that you can use the anchoring inside the guiding catheter to perform the trapping, and then you can exchange not the microcatheter, but just the position of the wire, the position of the different over the wire lumen, and exchange the judo 3 wire using the white hub of the Recross system that is over the wire on the tip.
Fantastic. That's why I think that this case and this explanation show you how you need to, when you're doing CTO, you need to think always to the next 1 or 2 steps in your mind, because you need to be ready to do that, because you have to know that you have an anchoring balloon that normally have to be always a 2 millimeter balloon, because you have the size of the side branch quite always allows you to use a 2 millimeter, and with the 2 millimeter balloon you can use anchoring balloon, you deflate, and you can do a trapping balloon with the same balloon. And you know that if you want to use only one device, you need to remove Recross from the tip, that is the filter XTA, and to switch the tip, to put the judo 3 over the tip of the Recross, and then you can advance as Gabriele perfectly explained, you can advance the Recross. So in this situation, after that, you cannot lose the position of your judo. You make, you remove, you change, and then you advance, as you can see here, with the same anchoring balloon, the Recross over the judo 3 that has to be switched, as I explain you again. It's very important, because you cannot advance Recross if you do, because if you don't switch from the blue port to the white hub of the judo, then you can advance. Look at how easily the performance of a Recross, how easily he advanced in the CTO and reach the distality. After that, as Gabriele explained, you need to change your judo wire with a regular wire, and then you can do this kind of PCI with this result. So this is if you do this case step by step, exactly with your mind, with your method, it seems to be really a straightforward case. But you have to face many situations. You have a bifurcation, the CTO in the distal part. You have to do anchoring balloon. You have to do dual lumen for a 2 wire, for 2 CTO wires. So you have many tips and tricks that you need to do, but you need to know that is very important. So, and I can go on with this video by Gabriele. Can explain another case of this utilization of Recross.
Yeah, absolutely. Okay.
You can use my presentation also if you want, but it's okay.
Oh, I'm sorry.
Because
okay.
I was running your live. So
what's the final image that we are seeing? Yours or mine?
If you want to close your.
Okay. Okay.
This is okay. You can go.
Okay, so this is another case. It's not really the same, but quite similar, because a case of total occlusion of the RCA with the proximal cap ambiguity. So the likelihood to go subintimal was quite high. So in this case, you have to consider the likelihood to perform the parallel wire, and then we have another anatomical aspect to consider. This is the proximal cap ambiguity, because this is not really, they are bridging collateral. So this is the first step to consider, and then the second step that there is a bifurcation at the level of the distal cap. So the Recross system was very useful in that case. This is the progression of the first wire that went not really subintimal, but inside the bridging collateral. So I decided to redirect the Gaia second wire that was advanced through the white hub of the Recross system in a sort of a single lumen microcatheter. And then the same things that happened to Roberto in the previous case, the wires crossed the occlusion but went in a side branch. But in this case, you don't have to lose the position because you already crossed the occlusion. So you have done the most difficult part of the procedure to cross the occlusion and to gain the distal true lumen in a side branch. So in this case, I advanced through over the Gaia second wire, the Recross without any problem, without the need of improving support, using an anchoring, and then using the second over the wire true lumen. This is the blue lumen. I advanced a second dedicated CTO guide wire into the main vessel, the distal RCA. Then after predilatation, there was some plug shift at the level of the side branch. So I performed a dual stent technique that was a decay crash. But after the deployment of the stent, I had this angio that show a big perforation at the distal edge of the stent. For this reason, in this case, you have to, first of all, you have to inflate a balloon to stop the bleeding and then think the next step. So this was a lateral perforation, so it's not possible to deliver coil to see the perforation. The only way is to advance covered stent. So in this case, to advance the covered stent is necessary to use the guiding catheter extension, because in this case I had to cross the strut of the stent and at the level of bifurcation when I perform a decay crash. So I advanced a guiding catheter extension, and then I deliver a covered stent. I perform the post dilatation and the optimization of the bifurcation with a complete sealing of the perforation with this final result. So this was a complication, but the first step of the procedure was very useful to understand how can the Recross device useful in this kind of procedure when you have to treat a bifurcation or when the likelihood to went subintimal could be very high. So this is the end of the first part of our webinar. We have a second part with other cases, but I don't know if Alessio want to make some comment, or are there some questions from the chat? Please, Alessio.
Yes, unfortunately, there are still no questions, so I invite all the colleagues who are taking part to this webinar to make questions and comments, because I think it's very important to discuss these cases that are quite complex, but as you have seen, they've been managed very efficiently with state-of-the-art CTO techniques and devices. So please interact with us. So I think that one thing that we can discuss that is not just the approach to CTO with your last case is the management of perforations, because perforations, of course, are the most complex complications to manage during CTO PCI, and so it would be interesting to know, in your opinion, what was the cause of the perforation, because it happened just after stenting, if I am right. So it's important for those who are following us and who start to do the CTO PCI to understand why sometimes it may happen that you open the vessel, you pre-dilate the vessel, nothing happened, then after stenting you see sometimes very dangerous perforation. So Gabriele, what can you comment on that, please?
Yeah, okay. In this case, we have to consider two different aspects. If the perforation is related to the occluded vessel, I think that in this case, it the disease of the vessel and sometimes some calcification that could be the cause of perforation. But in this case, I had a perforation into the side branch that was not the occluded vessel, so it was quite free from disease. I should stent it because it was a bifurcation, it was a big branches, and I didn't want to lose it. But in this case, maybe the stent was quite oversized. So in this case, the lateral rupture of the vessel was a consequence of an oversized stent, not really a disease of the vessel.
Yes, it's important as well to consider that sometimes when we do like parallel wire technique, we go subintimal. Sometimes we may go even subadventitially. So when we stand, we should not as you said, we should not oversize the stand, but even not to post dilate too much, because we even cause perforation because of the excessive post dilatation. Trying to get the perfect final result with a very good lumen, but we may risk to make to cause perforation as well. So
yeah, this Alessio, yeah, if I can make a comment, this is a very important point. Normally, usually, what's happened that you are, for instance, in the right, in the mid-right, subintimal, and you have a classification that is proximal to the subintimal part. Normally, you have a stent deployed that is under-expanded in the most calcified part, that is intraplaque, and then you have a more distal stent that is subintimal. In this situation, we have to be really careful, as you said, because if you go to post-dilate aggressively the stent in order to solve the problem of under-expansion, what's happened that the calcified part is not the calcified part that of the vessel that caused the rupture, but you post-dilate the stent because you have a under-expansion in the proximal calcified part, but the post-dilation caused an over-dilatation of the subintimal part that is subadventitial. And in this case, you have a rupture, a huge rupture of the vessel distal to the calcification. So this is very important. That's why it's using a lot of IVUS, we can see this situation. And when you have you stent subintimal, you have to be sometimes conservative in order to avoid this very dangerous complication.
Okay, thank you. I think that we can move to the second part of the webinar. So we've discussed about the Antegrade approach in terms of Antegrade wire escalation, parallel wiring, IVUS guided puncture of the proximal cuff. So very important issues or topics regarding the Antegrade approach. The side of the Antegrade approach is the so-called Antegrade dissection reentry. Because while with the Antegrade wire escalation, we try to stay in the intimal space, with the Antegrade dissection reentry, the aim is to go in the subintimal space and then to re-enter in the distal through lumen. This, of course, may happen as an initial crossing strategy. So we go directly to go into the subintimal space, or otherwise it can be a bailout approach when we fail with the Antegrade wire escalation. So when we should use the ADR as the initial crossing strategy? Of course, there are specific anatomies that we should take into consideration. We should use this approach as first approach when there is a well-defined proximal cup, when the quality of the distal vessel is good, because we need a good landing zone to re-enter from the subintimal space. We should avoid to use this approach when there are large side branches at the distal cup, because we risk to lose one of the branches. Of course, we should take into consideration this approach when there are not good interventional collaterals. So sometimes there are no collaterals at all. Sometimes we try to go by retrograde, and then we see that we fail to cross the septals or epicardial collaterals. So in this case, we can switch to this kind of approach. Of course, this approach can be used even in very long lesions because it's safer to go subintimal in these cases. So the Antegrade dissection reentry first we should make a dissection in order to navigate into the subintimal space, and then we should try to re-enter, and this re-entry can be done through different techniques. So first we have to manage the system to go into subintimal space, and this in most of cases is performed using the so-called knuckle wire technique. That is based on the use on a polymer tapered jacket wire, most of cases, like the Fielder XTA or XTR, that is advanced into the subintimal space with a distal loop, as is shown in this slide. And with the support of a single lumen microcatheter from the back, we push the wire into the subintimal space, and this is a very safe approach to navigate into the vessel structure. In most of cases, this is done in the right coronary artery, because we don't have normally important side branches in the body of the vessel. And then we get into the distal cup, and we have to re-enter, and this re-entry can be done with different kind of techniques. The oldest approach for the re-entry from the subintimal space into the distal lumen are the wire-based approach. So the oldest one is the star. In the star, we just push the looped wire with the support of the microcatheter, try to re-enter, and in most of cases, this re-entry occurs at the level of a bifurcation. Of course, this is dangerous because we may lose one of the two branches. The mini star is a variant of the old star technique, and this is performed with the new kind of wires like the Fielder XT series. So we make a J shape the level of the tip of the wire, and this may facilitate the re-enter into the distal true lumen. Another way to re-enter into the distal true lumen with a wire-based approach is the so-called LAST, redirection. So pushing the microcatheter at the distal cup, we switch from the looped wire to a stiffer wire like a Confianza Pro 12 or an Hornet 14, and we try to penetrate from the subintimal space into the intimal distal space. So we have to puncture the plaque from the subintimal space. So of course, these are complex cases, complex approach that not always work. This is an example of the mini-star technique. So this was right coronary artery occlusion at the mid portion. This was a diffusely diseased vessel. This is a 6 French amplats left that, as you can see, cannot cannulate the vessel because it's very with a very small caliber. This is a distal. This is a contralateral injection. There was just this septal branch that was available, that was with, I think, a partial epicardial course, complex. And indeed, this vessel was represented by a PDA. There was not an important posterolateral branch. So I started, in this case, with the Fielder XTR. This was the third case done during a proctorship in a lab where this time only a Corsair Pro was available. So I was forced to use a Corsair Pro in a 6 French guiding catheter. You know, this makes a lot of troubles in terms of trapping technique. So I advanced the Fielder XTR, and then I switched to the Gaia second because I had to some resistance with the XTR, and I get into the distal part of the vessel. Case you don't know if you are in the intimal or subintimal space. I try to redirect the wire in order to get into the distal true lumen, but I was not able to re-enter. So since I was, as you can see here, there was no large side branch, there was a disease at the proximal cup, and I was not able to advance so much the microcatheter because of the poor backup. I decided to do a mini-star technique, so I advanced a looped XTR, and fortunately it re-entered into the distal true lumen. At this point, what you have to do is to advance, once you confirm that the position of the wire is into the distal true lumen through the contralateral injection, you have to advance, of course, the microcatheter up to the distal true lumen to exchange the wire with a workhorse wire. What happens here was that since this was a Corsair, and there was no extension of the of the feeder XTR wire, I had some troubles to remove the corsair, and I lost the position of the wire, of the Recross wire. So it was in the subintimal, in a dissection plane. So in order to, I tried, of course, to get the wire into the distal through lumen, but I failed. So I decided to use at this point a dual lumen microcatheter, and the one I chose in this case was the RX. And the reason was even because this microcatheter can be trapped in the guiding catheter I was using for this case. The second wire into the over-the-wire lumen of the enhancer RX, and as you can see, I was able to get into the distal through lumen, fortunately, and this was the final result. So, of course, this kind of technique where the re-entry in the distal lumen is uncontrolled should be used nowadays in very few cases, like probably this one, where the re-entry was not easily done with other kind of approach, because of course the re-entry is not always predictable. So what, there is any comment from you, Roberto, Gabriele, about that, this kind of technique goes for moving to other kind of techniques?
Yeah, I think that this is an example that this kind of device, the dual lumen microcatheter, could be useful, not only necessary in CTO PCI, but also in standard PCI, because in this case, you perform a star technique because it was in front of a CTO. But in a standard PCI, sometimes you can have a subintimal tracking or a dissection of your standard guide wire, and you are not able to regain the distal through lumen. And despite to inject contrast or to manipulate the first guide wire into the subintimal space with the risk to enlarge the hematoma, you can leave the wire in a subintimal into the subintimal space, and you can advance the dual lumen microcatheter, and you perform a sort of parallel wire even in a non-CTO PCI. So this, starting from your case, we can underline how this device could be helpful even in case of complication of standard PCI.
Yes, even this was a CTO case. I was forced to use a 6 French guiding catheter. So in this case, it's very important to use devices that allow you to do the trapping technique safely, because as it happened in this case, I had the corsair in a 6 French. This made, of course, very complex the removal of the microcatheter, because I used the Nanto technique, but it was very successful. So it's very important, I think, that you have to choose your device even according to the equipment you are using for the single case. Roberto.
Great, yeah, I agree with you. I think that also talking about subintimal space, we don't need to think about that. Subintimal space is not our enemy, can be really our friend in many situations of our procedure. And as Gabriele and you explained very well, we can use device to re-enter from subintimal space also in normal PCI when you have a complication, when you have a dissection. That is very important not to inject contrast when you have a situation of subintimal hematoma, because you don't want to increase the hematoma. And if you're doing IVUS, you need only one case of IVUS to understand that how big is the hematoma in this kind of procedure. Also in the retrograde, when you are doing a reverse cart, you have a huge hematoma, and if you inject, you can make a disaster. And the second point is that the dissection re-entry, the Antegrade dissection re-entry, is a part of our procedure. Is in my experience in the last 2 years, I have more cases of ADR in many situations when retrograde approach is not feasible at all, or when you have a high risk of retrograde epicardial complex, and if you have a very good landing zone and you can manage a device to do controllable re-entry, not like star is a unpredictable re-entry, and normally I use only as investment procedure as a bailout. And when I fail all the other strategies, and I'm not doing an LAD CTO, and I don't want to destroy the vessel, the LAD, but I'm going to do circumflex or right coronary artery CTO. As last resort, I can do start technique, but as normally as investment procedure without stenting, and normally you can find after 2 or 3 months a good situation for next step of procedure. So talking about ADR, Gabriele, you can explain this in my laptop. You can explain this slide that show the difference between Recross, ADR, and cross-boss and stingray. So please go on if you want.
This is an example of the versatility of the Recross device and how can we use it as a re-entry system. In this slide are explained the different steps that you should perform during during the advancement of when you perform the ADR using the cross-boss and the stingray. You have to follow several steps. You have to change the single lumen, the cross-boss microcatheter. You have to change the wire, and then you have to advance the cross-boss, and then you have to when you puncture the distal true lumen, you have to remove the stingray to re-advance the microcatheter. So there are several steps using the cross-boss device, and then you have to you have to know how to use it. It's not really simple. You need a certification to use the stingray system. But the same concept could be done with using the Recross system as a re-entry device. In that case, thanks to the different position of the lateral exit port, you can advance it into the subintimal space as a single lumen microcatheter. Then you can use it, the over-the-wire lateral exit port, to perform the puncture from subintimal to the distal true lumen as a re-entry device. And then once you gain the distal true lumen, you can advance it as a single microcatheter, a single lumen microcatheter into the distal true lumen. So with the one device, you can perform the same strategy that you can do with the cross-boss and the stingray, but in that case, you are using just one device, the same device. So for this reason, it's very versatile and maybe less expensive compared to the cross-boss and stingray system.
Yeah, good. Yeah, good. I think that's if you want to be really complete, you want to do every kind of situation. I think that you need to be able to use both, because sometimes you are not able to re-enter with one device, and I know that can be expensive to use 2 devices in a case. But if you have the possibility to use both, and you have some cases in which you can succeed with one and you fail with the other one, as like crossing retrograde epicardial. Sometimes you cross with one microcatheter and you fail with the second one, or and the vice versa. In the next case, you can succeed with the second one and fail with the first. And but clearly, the advantage of Recross is that, as you explained very well, you have only 3 steps in the create a subintimal space and re-entry. With the ADR with stingray is much more complex with more steps, as you can see in red, and also the Recross have a very good profile, much better profile than stingray. Also, if we have the stingray LP, that is the profile is increased on respect of the first one. And you can see here again, and if you want to explain, Gabriele, this slide, but you explained very well clearly in the previous session. You have really here the white port hub and the blue hub with the stylet, and through the white you can go to the tip with the first wire, and you can exit here in this lumen. So you have one possibility and the second possibility of your wire. And with the blue hub, when you remove the stylet, you can exit here in the middle at 180 degree from the other exit port. So you have two exit port lateral, similar to the Stingray, and you have one more exit port here, and you have the possibility to use two wire. This is the difference between Recross and Stingray. With Stingray you have only one wire you can use, and here you can use contemporary two wire also for the re-entry. And I will show you this case. I think it's really interesting case, complex calcified LAD CTO. As you can see, we have two collateral from the septal and from the right, and we have a mid occlusion after the diagonal. And I tried to use the Recross, and the first was a classical dual lumen with the tip wire in the septal, and the second wire from the blue exit hub was a Gaia 3 that was not able to advance. It was a really huge calcification in the proximal cap, and then this was the failure of advancing of the Gaia, and I was not able to advance the Recross in a sort of this calcification. After that, I switched with a very good balloon, the Ikazuki 1 millimeter balloon, and you can see I was not able to overcome this calcification even with a very good balloon, and I push a lot, and without success. And then in this uncrossable situation, I was at the beginning of my procedure because I was not able to advance microcatheter or balloon, and I have a wire that was not crossing the occlusion. So I take the blimp. You can see here how easily the blimp crossed the calcification, but the Gaia went subintima. I perform a sort of knuckle, an intentional knuckle of the Gaia, pushing the blimp in order to overcome this problem. You can see the loop of the Gaia. And then I was able to advance the Recross. So we are in the step 1. You can see the previous slide that Gabriele explained. So we have a sort of subintimal entry with the first wire, you can see here, but was a Gaia 3rd. And we have the Recross that after blimp was able to advance. So we have a Recross in the subintimal space. At this point, it's very important if you want to perform an ADR, like a parallel wire, you need to understand very well the distality. You need to understand where is your vessel, your true lumen, because otherwise you are not able to direct any wire in the true. And that's why I make a sort of injection with the caravel. It was an 8 French guiding catheter here because it was a complex LED. So I take a caravel in the septal, and you can see here clearly that we have the Recross in the subintimal space, and we have on the left we have our true lumen. So if you want to comment, Gabriele or Alessio, or I can go on with what is your at this point, what is your next strategy, next step in this situation, Gabriele?
So first of all, this is a very elegant solution to inject from a different microcatheter in order to avoid an antegrade injection, because in this case you don't have any risk to enlarge the hematoma because the flow through the septal come from retrogradely. Then this is a situation in which you have to perform maybe a technique or a re-entry strategy. So in this case, this was a recross that you advanced distally into the LID, isn't it? Okay. So,
exactly. So we have the recross and the caravel. The caravel in the septal, the recross subintimal, and we need to do something to re-enter in this LAD. Yeah. And we know that retrograde is not very good because you see we have a septal connection that is at the level of the distal cap.
But the distance, the recross microcatheter is in a subintimal place, but not so far from the true lumen. So the hematoma is not so big. You were very good in this case not to enlarge the hematoma by guide wire manipulation or by contrast injection. For this reason, it was a very useful solution to inject from the septal ipsilateral channel. And then, so the space between the recross and the true lumen is very close. You can try to re-enter with a stiff wire using the lateral exit port of the recross.
Advantage that we have two possibility. We have two exit port, the white and the blue. We have two hole, and we can try to do that. And this was happen. I tried to do the re-entry with the Gaia third, but Gaia third was not enough stiff. This is very important point. You can see now when we do ADR also with the Stingray, we don't use anymore the Stingray wire. We don't use. I don't like to use the stick and swap, changing with the like Pilot 200. I like to do a stick and drive, but my favorite wire is Hornet 14 in this situation because we need to puncture from subintimal to true lumen to intimal, and in this situation sometimes Gaia third is not enough stiff to puncture, and he followed the dissection, and this what happened. You can see here clearly with the Gaia third follow the subintimal space, and now the situation is not so good as before. As I don't know what you think, you Gabriele and Alessio, but the situation before this maneuver was better, no? Because we have a dissection distal, and we can try to push the recross distal, or we can try to change the wire. In this situation, I decided to change with a stiffer wire, so I take the Hornet 14. This is the Hornet 14. And you can see the difference from Hornet 14 from the Gaia third. From the same white port, white hub, clearly. In the blue arrow, you can see the exit of the white port, and the feedback of this wire was completely different from the previous Gaia. And if we go back, you can see also the curse of our Gaia. You can see this movement is clear that is outside of the lumen, is all around the subintimal space. If you go back, we go back to see the Hornet 14 now is straight in the lumen. You agree?
Absolutely.
So,
but I think that it's even important that the Gaia, the band, the tip of the Gaia is very small. While probably when we make ourselves the band doing this such a maneuver like using an Hornet 14 or Confianza Pro 12, we make a little bit larger band. So even the type of band is important in such a procedure, because the re-entry, I think, is facilitated if you have a larger band at the tip of a stiffer wire. It's
very good point, Alessio, because you know that when you're doing re-entry from subintimal space with IVUS, I use ONET 14 with the large band, because you need to go from subintimal hematoma to enter in the small true lumen. Here is not like this situation, because as Gabriele said, the space between true lumen and subintimal is not so large, but this is a good point. With ONET, you can do a little a more acute band, and these two feature, the band and the stiffness, make the difference. So this is the contralateral injection, and here you can see that with this contralateral injection, we see how the distal LAD flow is compromised because of Gaia third dissection. So this is very important, because now in this situation we have an hematoma that is increasing from proximal to distal. So we have not a lot of possibility. So it was good that ONET gained the true lumen after the puncture, and this was the final, very good final result after stenting. Every branch is preserved, every septal, small septal, and also with IVUS that I make the IVUS run. I don't have here, question of time, we have a very small subintimal tract. So this, I think, was a really interesting case of use of Recross in many situations. Then I think that we have 10 minutes, and Alessio can go on with the uncrossable lesion. If you want, go with my presentation. I can show for you this presentation in order to be faster. Is okay for you?
Okay. Yeah, absolutely. Because,
okay.
So another important part of the Antegrade approach is what happens when we face an uncrossable lesion. That means that we have the wire already in the distal true lumen, but no microcatheter, no balloon can cross the proximal cap. Of course, there are different techniques that can be used in order to modify the morphology of the proximal cap in order to facilitate the penetration of a microcatheter or a balloon. But nowadays, most of the uncrossable lesions can be approached with this new device, that is the blimp balloon. This is a very special balloon, because, as you can see from this slide, is different from the ordinary balloons. This system has a very short rapid exchange part. As you can see here, the exit port is distal to the distal end of the balloon. The balloon is as a single marker, and this system that is been invented in order to, of course, as a scoring balloon, so to facilitate the dilatation of undilatable lesions, has been demonstrated to be very effective even in case of uncrossable lesions, because it's very low profile, helps in order to penetrate very hard proximal cap, as we have already seen in the cases that have been shown. So this system this device is very important to be available in our cath labs, because of course can solve complex situation in an easy way. We know that we consider the most complex part of the CTO PCI to get the wire into the distal true lumen, but sometimes uncrossable lesions can really make our procedure more complex and even be a cause of failure. So this is a case, I think, is one of your cases, Roberto, isn't it? So as we can see from this case, do you want to comment your case, Roberto?
Yeah, or you can comment. You can comment together. This is a post-cabbage patient. You can see this right. We have a double occlusion, proximal and distal, but the problem will be, as you will see, in the distal part. So you can, I can show you the case and you can comment. Alessio.
Yes, we know that cabbage patients are the most complex patients, because CTOs are normally very old, very calcified, so are the most complex lesions to treat. So exactly. This is yeah. I think, a perfect case to show the use of this new device in these uncrossable lesions.
Yeah, in fact, we have this case. I cross easily the first part. You see, no problem. But the problem was after in the distal part we have two problems. We have a bend. You can see here the bend. We go back to the beginning. You can see the distal here. We have a bend in the vessel here. So, and I fail with the XTA. I make a step up as you explained very well at the beginning with the Gaia third. I fail. Then on at 14, what do you think? It's good or not?
Well, all the 14, it seems to be subintimal, of course, the distal part.
Yeah, so outside of the on at 14. And then in this case, a very important technique that we were not able to explain in detail because of time, but sometime in this situation, what can be feasible? Do you like sometime step down with the Gabriele?
Of course.
Yeah. Okay. This was a step down with the filler XTA. You can see because of the bend in this situation, I like very much to do very important step down because the flexibility of this wire allows to stay in the lumen intraplaque. You can see. So with step down with filler XTA, I was able to gain the distality, but it's not over the procedure because I fail to advance the microcatheter. I fail to advance the balloon. This is a Tazuna failure. And then what can you do?
Yeah, in this case, the problem, of course, there are several techniques that you can try. That is to increase the support of the guiding catheter with an anchoring balloon. You can try to change the microcatheter to a stiffer microcatheter, or if you have a stiff microcatheter to a softer microcatheter. You can try different techniques. You can try to advance at this point a rota wire in order to try to modify, of course, the plug to make a rotablation to facilitate the crossing of the microcatheter. But there are other more complex approach. But if you have a single device that can cross an uncrossable lesion like that, of course, you make your procedure easier, and you can solve a complex situation in a very easy way. And at that point, you have just to put the stone. So as you are showing in this case, you have a blimp balloon and it crossed very easily. I think you did the case, so you have the hands working, but I think that it advanced very well. Even after the failure of the Tazuna, that we consider one of the best balloon for CTO lesions. So it's a very good example how this balloon can work.
Yeah,
yeah, this is a fluoroscopy storage. You can see how easily blink cross the blink. It was crazy. You see, you can see now.
Yeah, absolutely.
So please go on, Gabriele, to your comment.
Just a few considerations, because I think that it's important to know how to use it in the proper way. Because just a quick comment. It's a very short, rapid exchange segment. So when you advance through the J-Y connector, such as Copilot, you have to be very careful in order not to destroy the device when you advance through the J connector. Then after that, when you are very close to the lesion, because it's an uncrossable lesion, you don't have to push very hard this device, because if you push this device, you can lose the alignment between the balloon and the guide wire. In this case, it's ineffective because it's a scoring system. So if you push, the balloon can be not really aligned with the wire. So you have to inflate without pushing too hard. And then you have to wait, following the heartbeat, bit by bit. The wire with the balloon inflated can modify or can break the plaque, and then you can achieve a very quick and easy crossing of the lesion, as we have already seen in the Roberto's case. That's all.
Great. This that's why you see after the blimp dilatation, I can take a 2 millimeter Tazuna, and you can see how easily it crosses, because you crack this part of the occlusion, this calcified part of the occlusion distal, and everything was easy. And after that, this was a very good stent implantation. So I will show you the last case, and then we can go with the final comment. Was an instant CTO of the right. I crossed very easily with the filler XTA, and then I have problem with my Corsair. I have no way to do anchoring balloon because of the osteal lesion, and this is the crossing. And then I try to use everything. So very good balloon like Ikazuki 1 millimeter balloon, but you can see now it's coming. I risked to lose everything, but was not able to cross. And then Tazuna 120, 125, nothing. Then blimp. You can see how easily the blimp in this situation, with what Gabriele said, it's very important not to push too much in order to, because if you have if you diverge your balloon from the wire, you risk to have also complication, and this balloon is ineffective. So you need to wait, and then when you stop, or it's very important sometimes to use also a guide extension like Gideon together in order to not to make the diversion of the balloon that has a very short rapid exchange exit port. And then in this case, it was so easy to cross that after that, this is dilatation. You can see here in the mid of the right, the blimp. Then you can inflate, and then you can push again, because the profile is so good that after dilatation, you don't lose any profile for this balloon. And then easily crossing with the microcatheter, really easy. And then final. So I want to make my last comment, then I give the word to Gabriele and Alessio. And I want to thank my two friends for this two webinar. And I think that the interaction is very important, because we need to use our expertise to explain also to colleagues that are not so expert, that CTO are the most complex of this procedure. But if you start with a good method, with good material, good state of mind, and of course the first step is the Antegrade approach, you can have a really good result also in the most complex. So thank you very much, Gabriele and Alessio, and I give you the word for the final words. So Alessio, please.
Yes, thank you, Roberto. Of course, the pleasure to share these webinars for me is, as you said, great, because we are colleagues and friends. We share a lot of initiatives, so I think that is very important to do such kind of meetings, even if online meetings with friends. Yes, you said it's very CTO PCI are sometimes complex, sometimes less complex. The point today is to be able to choose the right technique according to the anatomy, at least as initial technique to start, and then to switch to from one technique to another in order to get the final result. Of course, the difference between an experienced operator and a less experienced operator is to understand what is the time to switch from one technique to another, and to choose the right technique to go on. And nowadays, with these the new devices that we have shown in these wonderful cases that you and Gabriele performed, we have understood how is important to have so versatile devices that can be used like Recross, the single microcatheter that can be used for any kind of scenario, from Antegrade wire escalation to parallel wiring to bifurcation CTO to re-entry. So it's very important to, I think, today have in the available this device in the cath lab, because it can make the difference in order to make a complex procedure in a more easier procedure and to be efficient. So that's what I think. Gabriele.
Absolutely, you are executive. So I completely agree with you. It's one of the added value of performing CTO PCI is that then once you know the techniques and the device, you can use it also in non-CTO PCI. So this is, I think, the added value of performing CTO PCI. Then during our daily practice, or even in complex PCI, you are able to understand how can you solve some difficulties that you can find during the procedure. So, and then the other things that has underlined by Roberto, I think that it's one of the most interesting things is sharing experience and sharing knowledge, because it's not always possible to try all the device or to know all the techniques at the same time. So sharing experience, like in these webinars, are very useful, not only for the attendees, but also for us, because you never stop to learn. So thank you very much to my friends and to IMDS for supporting this interesting initiative.
Last words. I think that's one of the best compliments I receive going proctoring is that a colleague said after learning CTO PCI, I understand that I become a better operator. So this is very important, because I think it's one of the key of our job, and I completely agree with this comment. And to conclude, I'm happy that we will have a third webinar, the 7th of July, talking about retrograde approach. So after that, we can have a complete series of our technique in every scenario of our CTO PCI. So thank you very much to everybody waiting for the 7th of July for the third webinar. Bye-bye.
Bye-bye.
Thank you. Ciao. Bye-bye.
Bye-bye.